The purpose of this class tonight is to go over intranasal Narcan that every level could do, all the way from, well, actually it's gone to over the counter, so a layperson could actually do it. But in Oklahoma, they're really pushing for the basics to do it. We have a pretty high death rate from opiate overdoses, and one thing that you could do is fairly not very invasive, which is do the nasal Narcan. As you see, we'll go over the protocols. I've also printed off the sheet that will give you the contraindications. We'll talk about all that stuff as the night goes on. So if you have any questions, ask, and we'll go over it and get through this. So Narcan was developed in the 1960s. It's an opiate agonist. Basically, it's going to work against the opiate that they've taken. Emergent overdose treatment in the hospital, and pre-hospital settings. Increased demand for a greater variety of available opioids, and there is an increased opioid use. It's going to be hard for me to say that tonight. So basically what you're reading is that Narcan is used for opiates. It will not work on any other medications like Valium or anything like that. It will only reverse the opiate. It will only bring them out of opiates. So here's some frequently prescribed opiates. The ones that I see most out here in Oklahoma are the hydromorphone. You see a little bit of methadone for people that are trying to kick an addiction. And it's not always just a heroin addiction. It's I was in an accident and I got addicted to pain pills. They'll give them methadone to help them get over it. The problem is that then they become addicted to the methadone. We see some morphine out here. We see some oxycodone, hydrocodone. We use fentanyl. I love using fentanyl as a paramedic. It's a great drug. It helps people with pain. It also makes them feel good. So you'll see codeine, and I don't really see any or as much as the whatever buprenorphine. I can't even pronounce it. So I don't see a whole lot of that. Those other ones we do see quite a bit of. You have a chance of seeing it out here. For the basics, I'm going to give you guys some tips on really what to look for, not just in their medicine cabinet, because you don't always know, because you have illegal opiates, which is your heroin. Sometimes they buy morphine or these other drugs from their friends, so they don't even have a prescription for it. Doesn't mean they're not taking it just because they don't have a prescription. So there's some things that we're going to talk about tonight to help you get the patient. So here's some frequently prescribed combination opiate medications. So Lortab, Norco. You guys probably have heard of all of these. Hydrocodone, Percocet. Percocet is oxycodone plus acetaminophen. Vicodin's hydrocodone plus acetaminophen. Percodan is oxycodone plus aspirin. And then I can't read the other ones because it's covered up. Sometimes what you actually need to watch on these patients, they'll take so much of this stuff that they'll actually have a acetaminophen overdose too. So try to keep if they'll tell you how much of it they've taken, that way you can report it to the receiving hospital. All right. So routes of administration of opiates by layperson. So oral, they could you'll see them chew up their transcutaneous patches. So basically a patch that they put on, they'll take it and they'll chew it up. Well, a lot of these patches are time released. So what they're doing is they're getting a huge dose of this right away. The oral or the chewing up the patches is what I've seen a lot of in Wichita. So they give them these time release patches. These guys would chew it up. Sometimes they melt them down, draw them up and inject them. So then you have intravenous injection of it. A lot of these manufacturers have gotten smart. They made them where they can't melt them down to inject them. And so if Jacqueline's here, she'd tell you, on the pharmacy side, whenever they come in asking for a certain type of medication, it's because they know that one could be melted down. And so she knows that they're a secret. She knows what they're going to do with it. Subcutaneous skin popping during the abuse of opiates. I don't know what skin popping is. I've heard of the term popper, but to me, it was something different than this. And So I don't know what that skin popping even refers to.
What are you talking about, Palmer?
It was something that they did, and they took. It'd be almost like, I don't know if you ever heard of a whippet, but it's basically a compressed air thing. They'd open it, they'd inhale the gas. They're basically huffing, but it wasn't something that was illegal to do. So that's what I know it as. But skin popping, I don't know. I'd have maybe I
Hang on, I
should.
want to look it up, but what does it say?
Seven
Skin
continues.
popping?
Yeah, skin
Okay.
popping. So Dawn's going to look it up for us, so we'll be able to talk about what skin popping is.
Right.
I'm going to go ahead and continue on the slides. Dawn, whenever you get it, we'll talk about it. So, I'm guessing signs and symptoms of an opiate overdose. One of the biggest things that you guys can look at is on your unconscious unknown. So you get to somebody's house, they're unconscious, you have no idea why. And understand, I'm not just talking about your local drug house where it's like, oh, okay, we're going here again. This could be your little old man that maybe he accidentally took too many medications. It could be somebody that's hypersensitive to the medication. But you go there and you look at their pupils, and if you look at their pupils and their pupils are pinpoint, you might want to think about going ahead and using that nasal Narcan. So meiosis is one of the first things I look at whenever I walk in. A lot of basics want to look at blood sugar on your unresponsive patients. I want to look at pupils, and because I could look at them right now, I just open their eyes, look at them. It takes me 30 seconds to get a blood sugar. So if you see this pinpoint pupil, and if you see that and they're unresponsive, most likely you're going to see the respiratory depression with that. So they're going to be breathing 4 times a minute. Be aware these people go into respiratory arrest very quickly. So you go in, you have somebody that's unresponsive. You walk in, they have snoring respirations 4 times, 5 times, 6 times a minute. Be ready to bag them until you can either get the Narcan on board, or until if you just want to take them to the hospital. But understand that they can go into respiratory arrest pretty quick. Decreased mental status that's usually what you're going to get called to, is that decreased mental status. So kind of get in the habit of walking in your house whenever you're doing on your unconscious unknown, or even on, sometimes I've went in and they say it's a diabetic problem. Walk in, open up their eyes, and they're pinpoint. We check their blood sugar, it's 128. We know that somebody has accidentally overdosed. It's usually what you guys out here, it's what I've run across more, is the accidental side of it than the intentional. But I will tell you that with our prescription drug crackdown, with the with pharmacy, now they're only able to, the medical community, they're only able to do is a 30-day supply, no refills. These people have to go into the doctor every 30 days to get these kinds of medications now. They're going to turn to other means. They're addicted to these medications. A lot of people are addicted to these medications. So we're going to see an increase in the abuse. Talking to Darren with law enforcement, with the sheriff's office, they are kind of getting ready for a heroin epidemic. I don't know why heroin's coming back, but it is. Get ready for it. And we're not always shielded. As you guys know, we have a meth problem out here, so we're not always shielded from the drug problem. We have the patients. We have the potential to have the patients out there.
This says that the skin popping is any of several routes of administration whereby street drugs are injected or deposited under the skin. It is usually a depot injection, either subcutaneous or intradermal. Skin pop scars, they're depressed, irregular, and circular. They are often hyper or hypopigmented. I would say that's just like track marks.
Yeah, so skin popping would be for, I don't know if the camera picked it up, but what skin popping is, which Dawn told us, is they give a sub-Q or intradermal also injection. So basically they're just putting it under the skin, letting it absorb a little slower. It's not quite as fast as an IV route, so their high is a little more sustained. So she said that it's evident by sores on their arms. Is that right?
Yeah,
or
irregular, circular, hyper or hypopigmented skin.
So irregular, circular, weird pigmented sores on their arm. So, thanks, Don. So, risk factors with opiate overdose. So hypoxia, we already talked about. You guys walk in and they're they're only breathing 3 or 4 times a minute. That could also lead to hypercarbia. So you guys use entitled CO2 here? You guys have waveform. So if you put them on your waveform, chances are you're going to see them probably in the 50s on your entitled CO2, if not higher, 50 or 60, depending on how long they went down. Well, they're starting to retain this carbon dioxide. So you're going to have this hypercarbia. So aspiration, a lot of times from this drug, they're going to puke. Well, they already have decreased mentation. They're possibly unresponsive. They vomit, and then they aspirate. And then we could go into cardiopulmonary arrest. So if they go ahead and advance to from respiratory compromise or depression to respiratory arrest, it will soon lead to cardiopulmonary arrest. So if they're not breathing, their heart's going to stop too. So the incidence of risk factors increases when other substances such as alcohol, benzodiazepines, or other medications have also been taken by the patient. So I told you guys that it's not going to work on your Valium, but it looks like the Valium will make the opiate worse. So be aware of that. So look for those pinpoint pupils and altered level of consciousness. So here we're just kind of going over the physiology of Narcan. It's pretty basic. Narcan or Noxolone displaces the opiate from the opiate receptor in the nervous system. So you have opiate receptors in your body. Whenever they do the opiate, it goes in, it sits there. This Narcan is going to go and displace it and take up that receptor. So they're still going to have that opiate in their system. Be aware of that, because even though that you've given them this Narcan, they start to come around. If they've taken a big enough dose of it, they still have it in their system. That Narcan is going to wear off, or it's going to release from the opiate receptor. The opiate's then going to hit the receptor. Then they're going to start going down on you again. So keep an eye on them while you have them.
If Rob, if this works, are they going to get violent, calm, or what are they going to do?
So Brian's question was, if you give the Narcan and it works, are they going to be violent, calm? Well, Brian, most every one of them that I have ever seen are violent, and so be ready for the fight.
How long does that take?
It's almost instant. You give that Narcan and you're going to start fighting. I mean, be ready for it. Within a minute. It's a full-on fight, especially if you bring them out. One thing that I have the advantage of is I can give it slow, so I can bring them out slow. Whereas you guys are going to be just shooting in there in air, which your absorption rate is going to be slower. So you stick in their nose. Your absorption rate is going to be a little different, so you might not get them as fast and violent. What they say, what I've heard people say is, "Oh, you've ruined their high. You've made them mad. Now they're going to want to fight you." I don't buy that. The reason I don't buy that is because I've run several accidentals, like a little old man that he never has taken heroin or morphine or anything like that, and they dose him with something like with fentanyl at the hospital, and they dosed him with a very small amount, something that shouldn't have knocked him out like it did. They sent him home. Well, family calls because he's out of it, unresponsive, and out of it. We get there and they kind of tell us that he'd been to the hospital. They gave him some medicine. I opened up his eyes. His pupils were pinpoint. Like, hey, little old man. I was still a pretty new medic at the time, so I still under the assumption that the people are fighting because they're mad you were in their high. So I'd get out my Narcan. I'd give him the full dose of Narcan, bring him out, and him and I were fighting. So after a while, he calmed down. He was still very confused. He accused me of stealing his money off of his nightstand right there. We were sitting in the ambulance, so he still didn't have any idea where he was. And so, I kind of think about it like this. Think about you just being in the deepest sleep you've ever been in, and then somebody suddenly jerking you out of that sleep. you as with a normal mentation, you're confused and you know might be a little scared depending on how fast you get jerked out. And it takes you a little bit of time for you to realize what's going on. Now take into consideration that they have this drug on board that clouds their judgment anyway. It can cause hallucinations and things like that. And you jerk them out of this deep sleep that has caused them to stop breathing, essentially. They're going to be confused. So you could I also think of your seizure patients. Whenever you get a true seizure patient that is post-ictal, it takes them quite a long time for them to allow you into their space. They're usually pretty confused. And so I associate it more with that than they're angry that you ruined their high. I'm not going to say that your true heroin addicts aren't angry about that, but you're going to see that fight with all of them. So be ready for it. Also be ready for them to throw up. So if you give it to them and they're going to throw up, you want to make sure that you're ready to put them on their side. Know who you're going to aim it at whenever you turn them on their side. So just have a puke bag ready to go because there's a good chance they could throw up. That's another reason I like IV. I can give it nice and slow and bring them out nice and slow, and they usually don't throw up. A dirty trick of paramedics, and I think if anybody really knew that this happened, they could actually get in trouble because you increase the risk of aspiration. But a dirty trick of paramedics to ERs that have done them wrong is to, right before they walk in the ER, they bag the patient all the way to the hospital. Right before they walk in, they slam the Narcan. Patient wakes up fighting and throws up. It's a hospital problem. Now they got to fight the patient. But I've never personally done that. Like I said, you're in a high risk of them aspirating, and that's on you if that comes out and found out. So I'm going to say that your nasal is going to work nice and slow. You still are going to probably fight much. Physiology of Narcan. This may result in the sudden onset of the signs and symptoms of opiate withdrawal. So you're going to have agitation, tachycardia, pulmonary edema, nausea, vomiting, and seizures. Kind of all the things I talked about. I've never seen seizures. I wish I'd bring them out real nice and slow. So I've never seen the seizure side of it. Tell you the truth, I've never seen vomiting. I have heard. I haven't had them after we get them calmed down, complain of nausea. But as far as pulmonary edema, I have no idea on that one because that would be something that I'd just listen to their lungs to see. I don't know that I've ever had it. Tachycardia, definitely. Yeah, you just pulled them out. You had that big withdrawal, that opiate, so they are going to be tachycardic. And definitely, I think agitation's a little bit of an understatement. They're usually fighting mad for whatever reason. So routes of administration of Narcan or Noxolone, endotracheal. As Kim could squirt it down the tube if she has to intubate the patient. I would say, Kim, try to think of another, rather than intubate this guy, let's bring him out first. It's kind of a new medic thing. They always want to intubate this guy, and it's like, well, look at his pupils. Are you sure you want to intubate him? I don't know if Michelle did that to you guys or not, but that's what they do. They'd always run that scenario in our paramedic class. So I got it drilled in my head to always look at your patient, look at those pupils before you go right to intubation. You don't want to intubate that patient. They don't need to be intubated. Intramuscular is something that I'm not going to do. I don't like doing IM shots. I just assume if I'm going to do that to go ahead and go IV. So intranasal, I think this is kind of the way it's going. You're starting to see a lot of states go to like I said, I say over the counter, but you still have to go to the pharmacist and ask for it. But most all states have gone to a basic protocol where they could do it by the nasal atomizer. So, and then intravenous. Obviously, I have expressed that that's probably one of my favorite ways of doing it is IV. I can control the rate. I can control how much I bring them out. What I do is I watch their breathing. I have made the mistake of just going ahead and bringing them out, thinking that there's an accidental overdose and fighting them. So So benefits of intranasal route for Narcan administration: equivalent clinical efficiency compared to intravenous Narcan. Intravenous access may be impossible to establish in chronic intravenous drug abusers. That is true. Gosh, some people usually got to have them awake to tell you where to start the IV because they know where their one good vein left is. So I guess this gives us a second route. The IM gives us a good second route. Or sorry, the IN, intranasal, that gives us a good secondary route. So, intranasal atomizers facilitate immediate administration of Narcan, reduction in the risk of needle stick injury and associated potential infectious disease exposure. Kind of the patients that we're dealing with out here probably are more of accidental as of now. So we don't have as big of a risk as the inner city does, but it's always a risk whenever you're dealing with needles and patients. You'd be surprised at the patients that maybe have Hep C or some other communicable disease that you didn't know about until later. So it's always safer to go with a needleless route. Do you guys use needleless? Yeah, we do too.
Yes.
A hospital, for whatever reason, doesn't, but we do. So key points for intranasal Narcan administration. Medical director approval is mandatory. A protocol from the medical director is mandatory, and training is mandatory. So we're doing the training tonight. Then we will have Dr. Gore sign off on it. We'll just basically what we're going to do is send in a sheet that says we're adopting the IN protocol that is put out there by the state, and then you guys are good to go on it. So we'll send in, I think we'll have to send in our roster of training. So everybody that is going to do IN needs to be trained on it. And we're going to go over some different things. I don't know, I want to get through these slides, but before I go too much into different things for you guys to look at. So the medical director retains the authority to limit or prohibit the administration of intranasal Narcan. My experience out here is that our medical directors are usually pretty good. They trust us in the field to make the decision. Are we going to bag this patient versus use IN Narcan? And I know that Dr. Eubanks, that's how he is. I'm pretty sure Dr. Gore is the same way. Unless you guys just really mess up, I think she's going to back you on what you decide to do. So the administration of Narcan by the endotracheal, intramuscular, or intravenous routes remains prohibited for EMRs and EMTs. So anybody that goes ahead and does the advanced class, which you don't have anybody doing that right now, or paramedics could still do these other routes. We have a couple going to Kim, your class, no, going to Michelle's class. So
Is she doing another one?
she's doing an advanced.
Oh, in advance. I was gonna say, I thought they weren't doing paramedic anymore over there.
Yep. I think what's going on, and she's doing it through Southwestern.
Oh,
And so I think what's going on, I think Southwestern's working on getting the paramedic program. So that'll be good. It has to be an accredited program now. So I don't think Burns Flat chose to do their accreditation process. So I don't think any paramedic.
I know we were the last class.
Yeah. So now they'll have to go through Southwestern because Southwestern, I guess probably because they're becoming accredited, has taken on the EMS side of it. And so that's good. That's good for EMS. It really is that we're finally there. But, I don't think it's going to change pay for forever in a year. But so intranasal administration technique. The dose of Narcan to be administered is determined by the medical director. I imagine Dr. Gore is just going to look at these protocols and probably sign off on the protocol. I believe, and I haven't read through all of them, but I believe for IN, you're looking at 1 milligram of Narcan per nair. So Narcan in the form of a liquid solution can be drawn up in a syringe or provided as a pre-filled syringe. Kim has chosen to buy the pre-filled syringe. I talked to my wife today. It's really the only way to go for this program. You can buy cartridge X, but that's at 0.4 milligrams. So it's a completely different dose than what you guys need. This dose right here is a 2 milligram dose, so you squirt half in one there, half in the other. But we'll go over that here in a second because just because that's how it is now doesn't mean that's how it's going to be packaged forever. So you guys need to learn to look at that packaging, make sure that you're giving the right amount. If I wasn't on camera, I'd tell you something. But, Narcan is a form of a liquid solution, can be drawn up in a syringe or provided as a pre-filled syringe. The tip of the syringe should be placed near or just inside the nostril. Placement of the syringe too far inside the nasal cavity may traumatize the nasal passage or cause epistaxis or a bloody nose. Kim has ordered these nasal atomizers, which has a stop on it, so you'd really have to try to get it too deep, and that's what we're ordering as well, is the same thing. You would really have to intend to cause some damage to do damage with that, because it's
No, I'm just kidding.
you were a jerk.
Just kidding.
We don't want to wait.
Remove the needle from the syringe prior to administration to prevent trauma to
Oh,
nasal
okay.
passage or puncture the nasal tissue or sinuses. You guys, let me see this. I just want to make sure. These are a lure lock syringe. It'll look just like this. There may be a needle on the end of it. To take that needle off, and it'll be a capped needle. To take that needle off, all you do is turn it to clockwise, counterclockwise to take it off. Then, what is it? Righty tighty.
Righty-tighty,
Righty tighty, yeah. Lefty loosey.
Oh, there you go.
So I was trying to do that for Brian, because I knew he'd know righty tighty, lefty loosey. I don't.
I do.
So yeah. So if you're gonna if that has a needle on it, lefty loosey, take it off. It's capped, and then just put your nasal atomizer on it. I'm not sure where you guys are gonna keep these on your ambulance, but it'll probably be real close to your Narcan. So. The use of mucosal atomization device, MAD, is it? That's what this is. It even says MAD nasal. On the tip of the syringe prevents nasal trauma and maximizes the delivery of medication to the patient. So this is the best way of doing it right here. What they're saying in there is you could do it just like this if you were in a pinch, but please use this. It'll save you a lot of hassle. So there's the mucosal administration device, or the MAD device. Here's the end of it, and you can see it looks just like the one here. So, there they are, administering it into the nair. So you just put it on there. You guys see that little mist?
They get choked up on the liquid coming in there?
This? No, you want to see it?
It'd be like a
Like a nasal spray.
after nasal spray.
Spray in a direction you don't want something wet.
So how, is everyone's dose the same?
Oh, yeah.
Yeah, 1 milligram per nair.
Everybody? No matter
Yeah.
Well,
what size you are or what?
Yes.
You're saying it's CC per shot.
What's that?
You said it's 2 CC or 2.
Yeah, and so
Well, 10
we'll
milligrams.
talk about that, because these are 1 milligram per cc. So you're going to do 1 milligram or 1 cc on each side. So
Why do lay people need these? You said that anybody can buy these. Why do
That's-
they-
what they're doing is they have recognized that there is a huge opiate problem in the United States. We're talking, when I say that, we're talking prescription drugs. You have a huge number of people dying for it. They don't need to die. It's really the risk to reward to this. And whenever you're talking about OTC stuff, a lot of times what they're doing is they look at how many people can this help or save versus how many people can this hurt. And the number is just astronomical. There's very few people that you're ever going to be able to hurt with Narcan.
Because Narcan doesn't do, if
Yeah.
you don't have an
There's
opiate on
very
board,
people-
it doesn't do
Yeah.
But I would
anything.
think that would even know to want it or to take it or keep it.
Yeah,
or when to use it.
You would be amazed at what your clientele know. They are very good at what combinations of drugs make a better high.
Oh, yeah, the drug people, but just our regular people.
Well, your regular people aren't the ones that are buying and selling prescription drugs. See, you are thinking of Granny down the street.
None of them people are gonna.
No, they're not going to. But you got to understand that
We're
they're
helping to drug people out so they don't kill
We're-
themselves.
exactly.
Yes.
And as your sentiment there
I'm just-
is very apparent, that you got to understand that they look at it as the greatest good for society. I mean, so you have this drug that is fairly it's fairly benign, but can save all kinds of lives. I mean, think about it like this. If you had a child that had a drug problem, because we all could have that child, would you want them to have that chance to survive if they messed up? I would. So there it is. It's
I'll
Narcan.
live with my child. It's everyone. I'm just saying, your mama messed up.
So anyway, the good outweighs the bad on the Narcan. And so that is why they're doing it. And I think you're going to see a push for people like Granny down the street to know about it. I think you're going to see a bigger awareness campaign, if you will, about Narcan.
So maybe even some of your home health people may want to
Oh,
try this because
Definitely.
more than just somebody.
So
Because your little old lady could be,
Yeah, when they
forget
find
she
it.
took it.
Because at least they know a
Her
little bit more
meds.
stuff than, say, your mom.
Mhm.
You get to tell your doctor you're on a patch, and then you take a pill
But-
they sent you home with, and then.
you do realize that your aspirin and your acetaminophen is actually more dangerous than this. So, it's all, the perception is, well, this was prescription, so it's dangerous. And that's not necessarily it. There's just never a recognized benefit to it.
This
Besides,
has been around forever. This is.
1960s, yeah. So now we're looking at this huge epidemic that we have. And now the best thing they come up with is get Narcan in the streets. It'll help people survive.
The drug users.
Yeah.
Process.
So it can, so
Essentially.
Well, they don't really want it because they don't want you to ruin their night.
Yeah.
Somebody's got to stay in stone so they can save the stone.
So anyway, our sentiment towards it is what it is,
And it is.
but it is available. So precautions with Narcan: the administration of Narcan may result in the rapid onset of signs and symptoms of opiate withdrawal. So they are on it. You give this, they can have, and we already looked at these. And what is there a little sound bite there? No, there's not. Looks like there's a sound bite. I was like, hey, that'd be kind of cool. These are the risks of Narcan. Let's go on. Safety considerations. Prior to administration of Narcan by all EMS providers, all patients should initially receive the appropriate medical interventions to provide support of the airway, breathing, and circulation. So here's the proper steps of things. Walk in, assess our patient. We recognize that they're not breathing adequately. We're going to start bagging them. We're going to continue our assessment. We notice that their pupils are pinpoint on our head to toe or our detailed focus. And we look in their pupils. We see their pinpoint. Then we'll go to the Narcan. So in theory, we should have been bagging that patient first. I told you what I do. I walk in, I see that they have pinpoint pupils. If I could get this on board quicker, I'm probably going to go to this. But if not, I'm going to go and have my back valve mapped.
So in other words, you're telling us if they got pinpoint people, use it.
There's not any other.
Yeah, if they have if they're sitting there talking to you, pinpoint pupils are just high.
But if they're
Well, still,
unresponsive,
you
they
can
got
spray this in your nose.
If they're
There's no
unresponsive,
trauma.
yeah, if
Yeah,
they
don't get injured or anything.
yeah, if you go on scene and they're laying there and they have pinpoint pupils, this would be you don't have any other reason why they're not missing half their head. Yes, this would be the treatment of choice. They used to call it an unconscious unknown. I don't know if they taught you that in paramedic school. They still teach that.
Mhm.
So basically, on any unconscious unknown, we could walk into this room, we could find somebody, and we have no idea. And we used to give them thiamine with our unconscious unknown. You guys don't.
No.
Thiamine kind of fell out of favor of the EMS world, just really kind of pointless. But we'd come in and we would an unconscious unknown, we are going to look at doing blood sugar or giving them dextrose. We're going to look at giving them Narcan. And there was one more, wasn't there, of that? Or was that the only two? So basically, any of those patients, we're looking to do those things.
Finding they only give anymore for the alcoholics that are staying in the hospital.
Yep.
But they,
Yeah, I don't even,
No.
it's not even on the protocols
No.
anymore.
no.
So anyway, you should, I'll run you through one that we ran. It was an accidental overdose, and Lindy Sasser was with me, and he was brand new. I think he was still in basic school, either that or a brand new basic. So we show up, and I was like, yep, we have an overdose. So she's in her chair, reclined, snoring respirations. I just walk in, look at her pupils, and Lindy, let's get her out to the ambulance, rather than drag everything in here. So we hurry up, we get her into the ambulance, we get her out there just as fast as I get everything in. And so I said, Lindy, you need to bag the patient while I get set up for an IV, because we don't have this intranasal. This is going to go a lot faster. While I get set up for an IV, so I can give her some Narcan. And Lindy is kind of going very slow. Lindy's a good guy. And so anyway, I hear her stop breathing. And so I was like, hey, Lindy, you might want to start bagging her. He's like, oh. And then he hurried up. Lindy was so flustered that day. But I think he learned a lot. But then we got the Narcan on board. So you do want to address, I guess the whole point of that story, you do want to still address your airway. You don't want to lay there and not be breathing. So, all right? Still do the same thing that you do as a basic. Now you just have this in your toolkit.
I'm gonna try to remember that. You've got to remember.
You're not going to let them die, Ladena. So, safety considerations. If Lindy's there on Thursday, he gets to watch this. And Lindy, I hope you don't mind that I used you as an example.
Don't feel bad, Lindy. I'm the only one that knows you.
Hey, we do now.
I use him as an example in every class, and I think he gets mad at me. That's all right. Sometimes I just make up examples with Lindy in them just to use him. So, safety considerations. All patients should be assessed for other causes of altered mental status and or respiratory depression, hypoxia, hypoglycemia, head injury, shocks, and stroke. And that kind of goes with the unconscious unknown that Kim and I are just kind of discussing on the side. The adverse effects following Narcan administration, particularly in chronic opiate users and abusers, may place and I can't see what it says, but I'm going to guess what it says. Place the patient at a higher risk of having your adverse effects. So they're going to have a higher risk of having those withdrawal symptoms if you give it to them. So due to the potential adverse effects of Narcan administration, medical professionals often elect to reserve the administration of Narcan to patients with known or suspected opiate overdoses for impending cardiopulmonary arrest, respiratory depression, or shock. So you get there, you see their pinpoint, they're still breathing 12 times a minute. You may be better off just putting them on the cot, watching the respiratory effort, so putting on that waveform capnography that you guys have, and transporting them, rather than deal with all the risks of them throwing up, becoming combative and stuff. But you do want to keep a close eye on their respiratory effort, okay? So the medical director should include parameters within the protocol for EMRs and EMTs on how to address the adverse effects. So agitation, tachycardia. You guys aren't going to do much for tachycardia. Pulmonary edema, if they start to drop their O2 sat, you guys don't have it here, but a good thing, if you do see that happen, and it is in the back of your head, you can always consider CPAP. CPAP will take care of that pulmonary edema. Nausea, you have a bag ready so for your nausea or vomiting, and then seizures. All you guys can do is make sure they don't hurt themselves and try to maintain an airway. Kim, you could go ahead and at that point treat the seizure.
But does the Valium work if you?
Yeah, the Valium should still work.
I think this has been a discussion that I know that they've been having in the ER with giving the Narcan these newer doctors are going, yeah, but you give all that Narcan, and then if they have a seizure, you can't do anything for them.
See,
But that's not,
I
because it's not a benzo you're giving.
no, yeah, you're giving a benzo for the seizure.
Well, I mean,
You're
but
giving
that's
it-
what
Yeah,
I'm
no,
saying.
but you're not
giving
having a
it-
withdrawal from benzo
Right.
like you would Ramazicon.
Yes.
So you go and you have this seizure patient or this seizure patient they overdosed on a benzo, and you give them Ramazicon rather than back them out of it, and then yeah, they are going. Chances are, if you pull them out too fast with the Ramazicon, you're going to cause a seizure. I would think, and I'll do some research on it, Kim, but I would think that your seizures cause from something completely different than the benzo withdrawal. It's an opiate withdrawal. That's how you treat it.
Yeah.
As a matter of fact, whenever you have your clinics, your get clean clinics, a lot of times they have that on hand for the people that start seizing. Alcohol, DTs, we're going to give Valium. It's kind of the same thing. We're looking at different reasons, but I'll look into it and I'll send you an email. I'll send all you guys an email, whatever I find, since you guys are all going to be doing this, so you can be aware of it. Not that you guys can treat the seizure, but Kim can. So, safety considerations: the half-life of Narcan is relatively brief, as short as 30 minutes. So, all patients who receive Narcan must be monitored closely for recurrent symptoms, including altered mental status, respiratory depression, and circulatory compromise. I told you guys that after you give it, if they have enough opiates on board, they could go back into those things that you were treating in the first place. So.
And we can do it again once they go back.
Yeah, times one. All your protocols says you can give it one additional time. So.
Can you give them too much of that?
No, you're not going to give them too much of this. Your only risk of this. Here, so we have the. I've got. We'll just see if there's any contraindications. So your pharmacokinetics is onset of action within 2 minutes after, a lot faster than that, with duration of effects up to 2 hours. Contraindications: known or suspected narcotic substance use or abuse without cardiopulmonary compromise. So what they're saying on a contraindication is this person is your known heroin addict. They are at you go there, they're out of it a little bit, but they're still maintaining a good airway. They're still able to protect their airway. You don't want to shoot. You don't want to hit them with Narcan. Just take them in and watch them. So post-intubation is known or post-intubation in known or suspected narcotic substance use or abuse situations. Avoid whenever possible of known or suspected narcotic addicts. In these patients, use the smallest clinically effective dose possible, titrating administration slowly to avoid acute narcotic withdrawal. So
you don't give them as much if they're.
yeah, and that you're looking at that. You're looking at what I was telling you guys earlier. I control through IV. I'm able to give a little. Let's see if they tell us dosages. If they give us the ability to change
This
it.
have a supply that's on the next one.
Up to 2 hours.
Here it's saying in ineffective breathing activity, 0.5 milligrams IVP, IOP, or IN, so intranasal, may repeat to a maximum 4 milligrams. So it looks to me like you can do a half a milligram. So on this right here, it's 2. It is 1 milligram per ml. So you can just do half a cc on it and see. And that's. You guys got a monster house, man.
No, that's the neighborman throwing away his beer bottle.
Oh,
Sorry.
that's what my trash can would sound
He
like.
buys 30 of them every night, so.
So anyway, yeah, when like I kind of told you guys, I haven't really read through all these protocols. I just do, I just titrate mine through IV. So I haven't read through all the IN protocols. If you have them there, it should tell you your IN protocol. It should tell you whether you can titrate, which by reading this, it looks like you can. 0.5, that's, you're looking at 1 milligram. So you're looking, the the least I usually do is 0.4. So you're right about there with that. And you couldn't measure that on that.
It says to always titrate administration slowly.
Cool. That's good to hear that you can actually titrate with IN. So nice and slow, half a milligram at a time. That's what I'd do. So here's a practice case. You respond to known drug abuser who was found unconscious with a hypodermic needle inserted into her arm. Her pupils are pinpoint, and she has not. Where am I at? She does not respond to painful stimuli. Upon assessment of vital signs, her blood pressure is 110/70, pulse is 60, respiratory rate is 2, and a pulse oximeter reading of 84%. What is the first action you'd like to take?
Bagger.
Yeah, well, so obviously we want to address that airway issue, right? Yeah, if you guys are doing a state checklist or anything like that, yes, we're going to do, obviously we're going to bagger first. And did I not have those check forms with me?
Actually, you know, if we were doing a paramedic class, they'd be like, you better be intubating.
So, yeah.
For respirations of two.
2. So, I agree with you guys. We're going to go ahead and we're going to start bagging this patient. We're going to take care of that airway. This patient is apneic as evidenced by her respiratory rate of 2. The appropriate initial action to take is to open and maintain the airway and administer oxygen via bag valve mask. Bravo, bravo. Therapeutic interventions to support the patient's airway, breathing, and circulation should be initiated prior to administration of Narcan. So we need to go ahead and address this airway issue first, correct? So that's a really bad thing that paramedics do whenever they're brand new. Is we always want to jump to the more advanced things. What drug can I give them? Well, really what we should do is we should stay with the basics and then move from there. And so that's what you guys need to do as well whenever you guys are administering we're thinking about Narcan. Go ahead and stick with the basics and move from there. So, all right.
So you're bagging this lady.
Uh-huh.
How long, do you want to get her O2 up? I mean,
Yeah, so you're just going to do your...
before you give her the stuff, or do you just wait?
What you're going to do is you're going to start bagging her until you can get the medication drawn up and you're going to go ahead and finish your evaluation and then determine, yes, we want to give them the medication. You don't have to wait until she's at a certain O2%. Do your breath, take it off, do your half milligram, nice and slow, and then just start bagging her again. She will start to breathe again, and then all of a sudden you'll see her eyes open.
I didn't say change baggers.
Yeah. Hey, I'm gonna go drive. See you later.
Change baggers.
Change baggers, and I'm driving. So yeah, no, you don't have to wait till you get to a certain number. You just need to go ahead and initiate that bag valve mask first. And don't get rid of your bag valve mask because there's a chance that as you're driving down the road, she's gonna just slowly kind of wind back down, especially if you go with half milligram, half milligram at a time. There's a chance that you're gonna need it again. So we're bagging her, we address it. Okay, another half milligram, bag her until she comes back around, until she's supporting her own airway. Does that make sense? So whenever we're bagging, AHA's new standards, just so you guys know, is 1 breath every 6 seconds. But you guys have this cool device on your ambulance. It's called waveform capnography. And I highly recommend you guys get in the habit of whenever you're going to bag a patient, is you guys have the nasal things yet? Okay. That you put that on there and bag in between 35 and 45. Before I ever used waveform capnography, I probably would have not told you that, but using waveform capnography changed how I bag my patients. So rather than just going, I still shoot for 1 breath every 6 seconds, but I could watch that waveform. If I drop below 35, I know I'm breathing too fast. If I go above 45, I need to speed up a little bit. I'm going too slow. So we could go over that stuff at another time if you guys need to. Once you get that concept, it's like, oh, okay, I got it now. But it took me a little while. It's as simple as it sounds. After you leave, you're gonna think about it. Now, which way was that? Or you may not. You might already have it. I don't know. It took me a while.
think,
We don't, I didn't know we had.
Oh, yeah, you guys don't know? Yep, we could definitely go over it. I love.
Last I knew we didn't have it, we were gonna get it.
We used it the night with the.
All right, so
I'm glad more with it.
our second patient, response to the home of a diabetic hospice patient with cancer. He has decreased mental status and pinpoint pupils. His wife checked his blood glucose prior to 911, and it's 170. The patient was at his baseline mental status until she applied the transcutaneous fentanyl patch that was recently prescribed for pain control. He has a blood pressure of 130/80, pulse of 70, respiratory rate of 18, and pulse oximetry of 95%. What do you guys want to do?
scoot over a little bit.
Sorry.
Yeah. Sorry.
Oh, okay.
Yeah.
Is he awake or?
Check his pupils. I guess.
Yeah, so his pupils are pinpoint, which,
But does it say he's alert?
nope,
Mental status.
mental status, mental status.
Blood sugar is
Shoot him up with some
170.
juice, see what happens.
He needs some.
Here's the
pain
important-
control.
Here's the important things in this case, okay? We're not at or near cardiac or cardiopulmonary arrest. We're at 130/80, 18 respiration, and 95%.
Vital signs are good, so he's probably
His
just
blood
having a
glucose.
reaction.
What would you have done for this guy? Let's say you're going to transport him. What would you have done for this guy before you knew about Narcan? Transported him, right? You would have just watched him, right? Let's do it. That's what I'm going to guess. But Jason wants to juice him up. And
Juice him up. See what happens.
you should follow the protocol that is provided by your medical director. This patient has stable vital signs. Your medical director may direct you to administer intranasal Narcan, remove the fentanyl patch, or transport the patient without any additional medical intervention. The medical director retains the authority to allow, limit, or prohibit the administration of intranasal Narcan.
Well, if we take that patch off, how long does it take to, I mean, it's already so.
Yeah,
You're not-
Those transdermal patches, I mean, you're just stopping the future absorption. It's probably still going to take a little bit of time for them to come
we'll be
around.
done with it.
So
Yeah.
if they're not in respiratory distress, you don't give them that stuff.
I personally wouldn't. I would just watch it. So we had an
So if
8.
they're just out of it,
Yeah.
you just let them go.
Just let them go. Unless you really don't like them and you know they're a heroin addict.
I just want to see what it does.
Here,
No, you don't.
have you ever seen the movie Bringing Out the Dead?
Nope.
With Nicolas Cage.
No, face off.
Yeah, I know that one.
Don't do the dead stuff.
Yeah, I wouldn't, on that patient. Now that last patient, yeah, I would have given it nice and slow. I would have titrated. So if you have any questions, you call the Oklahoma State Department of Health and Emergency Systems at 405-271-4027.
I thought we were gonna call you.
No, guys, feel free to, in all honesty, feel free to call me. And if you if you come up with a list of questions or you guys are thinking about this and you want some things answered, email me. If I can't answer them, I'll send them on to Kim and she can get them to Dr. Gore and have her answer them. But I'm pretty sure that, or however Kim's going to do it, but I'm pretty sure Dr. Gore is probably going to sign off straight across on that. So, yeah, it's not that big of a deal. Big thing is if you ever have questions, you're not sure, you guys always have a lifeline. And I'm not sure that if I've ever told you guys this, but your lifeline is you either call Dr. Gore. If she doesn't answer, call the receiving facility and talk to the ER physician. So you have online medical control. Hey, Dr. Gore, or hey, receiving facility, I'm on scene with this patient. They gave him this transdermal patch. She said that his mentation decreased after she gave it to him, but right now his blood pressure is 130/80. His respirations are 18. He's 95% on room air. His pupils are pinpoint. Do you want me to try Narcan, or would you just like me to transport? I could try, 0.5 milligram, and they'll let you know what they want you to do. But like I said, on this guy, I probably wouldn't have touched it. But it all depends on who the doc is and what they want. So, but you always have that lifeline. You can always call. If it's in the middle of the night, I probably would spare Dr. Gore and call the receiving facility. If you like her. If you don't like her, just call her. Any other questions? So, all right. So if I use this for the monthly meeting at Roger Mills, if you guys have questions, text me and I will answer them.
Or you can do that.